These are the cases that are going to come up in the abdominal medical station. This is not rocket science, yeah? This will come up everywhere. This is not completely shocking to anyone who's listening to me right now. At the very least, you should be prepared to answer a few questions on either chronic kidney disease or chronic liver disease. Those two things you should just know a little bit about. So at the very least, in the cheese and onion or whatever book you're using now or whatever website you're going to, those two things you should at least know, at least in some depth, yeah? You should be able to dig into that. I would expect a good final year to also talk to me a little bit sensibly about a big liver or a big spleen or both. And finally, abdominal masses are a bit weird and wonderful. I mean, they tend to just be subdivisions of everything. So what I'm going to cover today is I'm going to touch on the kidney and the liver. I'm not going to be able to do abdominal masses, but to be honest, realistically, abdominal masses are going to be either surgical abdominal cases or they're likely to be part of a hepatomegaly or something like an adult polycystic kidney disease or something. So they'll normally fold into those other cases anyway. So really, you really need to know chronic kidney disease and chronic liver disease. Those two things you really need to understand, yeah? Because if you think about the kind of examiner you're going to get in these stations, it will pretty much always be a gastroenterologist or a renal physician. And that's kind of their bread and butter. So you need to know those cases because that's kind of what they deal with day and night. And if they get bored and run out of questions, they're just going to start talking to you about kidney and liver disease. That's it. So you need to know a little bit about that. Now, let's get this out of the way because every medical student loves tearing themselves into. I was going to say they love putting themselves into knots about types of incision and what the right way of describing it is. Now, I've examined for medical finals before, and to be honest, in most mark schemes for this, there are no extra marks for getting the name of the incision right. I suspect surgical mark schemes may be different, and surgeons would certainly be more impressed if you had the right wording. So if you want to call that's your various scars, but if you want to call specifically the kidney access scar a Rutherford Morrison incision or a hockey stick or whatever you've been taught to call it, that's completely fine. You can even call it an oblique incision. As long as you mention the scar, you'll get the mark. I don't need you to give me the exact verbatim 1922 definition of whatever scar you're talking about. I'd like to know that you kept your eyes open and inspected the patient. That's what I need to know, that you saw a scar and said, there is a scar there, right on the abdomen, and said something like, it's near the right iliac fossa, it's oblique, it's kind of going, it's angled, whatever way you have of describing it. In the heat of the moment, if you forget, that's fine. Just mention the scar. Mentioning the scar and keeping your eyes open are important. Now, I'll start by stipulating that all the images I'm going to use are from Google Images, so these are not patients I have seen. These are all nicked from Google images, and they should be open source, so I'm hoping I'm not going to get in trouble for using any of these. Okay, this patient, unsurprisingly, now if I was in a lecture theatre, I could point and pick on people. The image on the left is clearly an AV fistula. This is an aortovenous fistula. Specifically, this is probably a radiocephalic fistula, probably the radial artery, or maybe the brachial artery. Looks a little bit low to me. Could be the radial artery going into the cephalic vein. This fistula becomes big because there's arterialization of the vein going on. So the artery and vein are connected there. And you can see from the bruising that it probably has been needled recently. So I would say this is a mature fistula, probably. And this is a fistula with signs of use because of the active kind of recent bruising around there. So probably this has been needled recently, which means this guy has probably been on dialysis recently. So that's the way to look at a fistula. One of the questions, and there's so many, see the thing is, the timing always limits me. There are things I'd like to throw in here, like extra bonus stuff would be a consultant stopping you and saying, how do you know the fistula is working? How do you know it's functional? And if I asked you that, what you might say. Now, I'm sure you guys have all been doing your reading and are super intelligent, and you would tell me that, well, if the fistula has a thrill on it, i.e. I can feel blood flow underneath it, it probably is functional, yeah? The other way you can check if it's functional is listening for a bruit over the fistula, which you'll probably get because there's going to be turbulent flow there. So you could listen for a bruit, and that would be the main thing. The other things you can look for with a fistula, what complications can you get from a fistula? Well, because you've connected the artery and vein like that in an abnormal manner, which your body's not used to, you can, with a large enough fistula, end up with elements of heart failure, so high output cardiac failure, because you've got this massive connection between artery and vein without a big capillary bed in between. You could end up with high output cardiac failure if it was a big enough fistula. You could also end up with the fistula getting clotted off. So you could get thrombosed. You could end up with the fistula getting infected. So, and then the next question you should be expecting from the consultant is, well, how do you know if a fistula is infected? Well, what are the signs of infection? So if the fistula is hot, tender in particular, if it's very painful, the skin is red over it, you would suspect the fistula is infected. If it's infected, you don't want to needle an infected fistula. You would stay well away from there because you don't want to put bacteria directly into the bloodstream, ideally. So what about this guy on the right? This, and I don't know if you can see my mouse, you probably can't because of the various streaming things. I don't want this whole thing to crash, so I'm not going to use my mouse too much. This guy on the right has got a dialysis catheter. Now you'll know, because you guys are very good medical students, you will know from your renal ward rounds that this is a tunneled line. This catheter, and there are different names depending on which part of the UK and which kind of center you're at and which type of catheter you're using. This is a dialysis catheter, but this is a tunneled catheter. It's been stitched in and it's tunneled into a large vein. And this catheter is probably a long-term dialysis catheter. The other option is a non-tunneled catheter that goes into the neck like that, or it could go into the leg. And those non-tunneled catheters, and I apologize the image isn't great, those non-tunneled catheters you would probably see in patients who are on emergency dialysis or emergency hemofiltration in an intensive care unit. The long-term tunneled lines are less likely to get infected and are normally placed where you saw them in this picture. So that's what they look like. And that's what dialysis catheters look like. The other thing I want you to keep your eyes open for, so you see this patient with a nice Rutherford Morrison, or you see a kind of a nice incision which looks like a kidney transplant, and you go gung-ho on the catheter, whether they've got an abdominal, and I haven't put up a picture, unfortunately. I haven't put up a picture of a peritoneal dialysis catheter, but I'm hoping you can just Google that yourself. You'll go gung-ho on all that. Just remember to look in the neck really carefully. I want you to look for this scar. And I apologize, the resolution's not great. You can Google parathyroidectomy scars and look it up yourself. These scars can be small. They can be hidden in the neck crease because if the surgeon's any good, and they all are very good, they will hide the parathyroidectomy scar in the neck crease so the patient doesn't complain they've got this disfiguring scar. And this scar can be quite hard to see if you don't look for it carefully. So really ask the patient to lift their head, turn away from you, get rid of some of the skin folds, and see if this scar is there. If it's a patient with chronic kidney disease, they may well have tertiary hyperparathyroidism, and they could have well have had endocrine surgery, specifically a parathyroidectomy, and that's what that scar would look like. It can be very, very subtle, and it's always very nice if you pick it up. Obviously, you're not going to fail for missing something so small, but it'll look really slick because it'll look to the examiner like you've clearly been around patients with renal failure to look for that scar and pick it up. So these are the things your presentation for kidney disease must cover. 1, the modality of renal replacement therapy. The patient in your kidney case is going to probably have chronic kidney disease. Otherwise, it's unlikely for them to, there's no real benefit to bringing that patient into the exam. So you're going to have to cover what is their current modality of renal replacement therapy, i.e., how is this patient currently surviving in the world? What is the way? Is it dialysis? Is it what? And if they have a transplant, if that's the modality, is it currently working? And for that, you'll end up talking about Uraemia and fluid status. I will come back to that. Fluid status should be straightforward, but Uraemia I will come back to. So signs of Uraemia and fluid status can tell you if the current renal replacement therapy modality is adequate or not. You'll have to think about the cause of their kidney failure. Now, this is the easy bit. You know that the commonest causes for kidney failure in this country and most of the world, I would have thought, are diabetes, hypertension, right? So the top 2 are pretty easy, whichever one you level peg. It could be hypertension, diabetes, or diabetes, hypertension. But those are among the top 2. So the first 2 or 3 of that is pretty straightforward. So we can think about causes of kidney failure pretty easily. And I'm hoping you won't be going straight in with vagus granulomatosis because you don't want to end up talking about Cianca. You want to start with diabetes and hypertension. So you want to start with common and easy stuff that you can talk about very easily. And of course, you can end up going into vasculitis after if you'd like. If they've got a transplant, I put this in brackets, if they have a transplant, then you'll also want to talk about signs of immunosuppression. Signs of immunosuppression are very, very classic. Even if it is just to tell the examiner, just tell me that the patient is not Cushingoid at the bedside. That's enough. You don't need to remember gum hypertrophy and fine tremor from tacrolimus. It's excellent if you do. It looks better if you do. But if you forget all of that in the heat of the moment, signs of immunosuppression, steroids, Cushing's, just remember those signs and you can rattle those off while the alarm goes off and you have to move stations. So if you forget everything else, just go to the signs of Cushing's. So signs of violaceous striae on the abdomen, signs of a moon face, or signs of a subcutaneous fat pad on the back, whatever your signs of Cushing's are that you can remember. Just give me a few of those. And remember, I'm a big fan of actually writing down your presentation. You will find bunches of these everywhere. Every book's got one. You can find them for free online. So don't worry if you don't ever see this again. You can write your own one down. And I would recommend you do, because like I said, there's only chronic kidney and chronic liver disease. So you might as well write down how to present those two cases well, so you don't trip over your words. This is how I presented a patient, or I would have presented a patient in my finals. Of course, I was probably never this slick, but you want to get at least 50% of this out in the heat of the moment, and then you look amazing. So you want to practice this in front of the mirror, practice this even read out as a script in front of your colleagues, so that when you've done it 10 times, saying phrases like the current mode of renal replacement therapy, blah, blah, blah. If you can just get those words out without having to think about them, you will look a lot slicker in the exam. I examined this gentleman's abdomen. He has a scar in the left iliac fossa with a firm underlying mass, which is smooth and non-tender, without overlying erythema, consistent with a kidney transplant. You'll notice that when I present any mass, I always throw in a couple of these words. And of course, with a proper mass being presented, you'll have to throw in a bit more than that. But this is sufficient when it's part of a larger exam like the abdominal station. So I've described that it's firm. I've said it's smooth and non-tender without overlying skin changes. That's probably sufficient. That's probably overkill, if anything. There is an AV fistula or an aortovenous fistula in the left arm with signs of recurrent use or recent use, suggesting this renal transplant has failed. The blood pressure is elevated at 150/90 in keeping with renal impairment. Your patients with chronic kidney disease will have hypertension, because CKD will give you hypertension. That's one of the signs of just kidney disease in general, acute or chronic. The current mode of renal replacement therapy is likely to be adequate as the patient is euvolemic without signs of pedal edema. Now, euvolemia, as far as you're concerned at the bedside, is just going to be whether they are, well, if the patient cannot lie flat because they're on oxygen and breathless, so they've got clear pulmonary edema, which unlikely to come to your exam. If they have that, then they're not euvolemic. Obviously, they're overloaded. High JVP, pedal edema, that's more likely to be present in your patient, because they're not going to give you someone in crashing renal failure in the exam. They're just not going to do that, with pulmonary edema. They're going to give you someone who's stable and can come to a clinic. So that's the kind of patient you're likely to get. Notably, the patient is not Cushingoid. The cause of this patient's end-stage renal failure or renal disease is not readily apparent. I'd like to inquire about risk factors for chronic kidney disease such as diabetes and hypertension. I'd also like to dipstick the urine to look for glycosuria, if the patient makes any urine, of course, which may suggest diabetes is the underlying cause, or blood and protein, which may indicate an underlying glomerulonephritis. And that's it. That's a rough kind of presentation for how you should present a renal case. You've covered pretty much everything in there. Little signs you can look for at the end of the bed. Asian patients with signs of BM stick prick marks on the fingertips can be a sign of diabetes. Look really carefully around the bed for that. Diabetes is commoner in Asian patients. Adult polycystic kidney disease, if you find a big palpable kidney, they may even have a Rutherford-Morrison for a previous kidney being removed. The other thing you can look for with AP-CKD is hepatomegaly, of course, that they can also have hepatomegaly because of liver cysts. If they have purpura or lupus factor, which is unlikely, I really think that's unlikely in the exam. And, then that kind of purpuric rash, you're thinking vasculitis or lupus. More likely, I think, than that is probably stroke and bypass scars. So if they have very obvious hemiplegia on one side, or if they've got a sign of a previous coronary artery bypass surgery, big midline stenotomy scar, then this is likely a vascular path. This is a patient who's got atherosclerosis, who's probably got renal artery stenosis bilaterally because those arteries are just clogged with cholesterol and atheroma, and that's the cause of their kidney disease. And that makes it slightly easier. And of course, vasculopathy goes with diabetes plus or minus hypertension. So either one of those, or both. How do you assess your graft function? Well, firstly, if the patient has any of these signs, they have graft failure. Anemia, fluid overload, uraemia. So anemia, of course, a little bit of a soft sign, but you can look at that in the eyes, look for that in the eyes, and see if they look very obviously anemic. Now, different ethnicities, it's a little bit difficult to tell. It's not always straightforward. So it's not the strongest sign in the world, but very anemic patients will be obviously anemic at the bedside. Fluid overload, like we already discussed, and signs of uraemia, which I'm going to come back to. I'm going to come back to signs of uraemia. I want you to think as I'm talking, just have it in your back of your mind. What are the signs of uremia? Because I'll tell you this, there are no signs for high creatinine. You can have a creatinine of 50 and you can have a creatinine of 50,000 and you would have no signs that your creatinine is elevated. Creatinine doesn't give you clinical signs or symptoms, nothing like that. What you get signs from is the urea going up. If the urea is high, you will get uremic and uremic signs. And I want you to think about what signs you might get. Signs of rejection of the graft are heat or tenderness over the graft. This is more likely to be a question. You're not going to be examining someone with a failing graft acutely. They might say, what signs would you expect? Well, if the graft is being rejected by the body, it would be hot. It might even be tender. So it might be warm to the touch, and the patient might complain of pain over the graft site. If the patient with the kidney graft is having active renal replacement therapy, i.e. a fistula which has been needled recently, that means that they've recently had dialysis, i.e. the graft must be failing. There's no way otherwise they'd be having dialysis. Why would they if the graft was working? So if they've had an active renal replacement method beyond the graft being used recently, by definition, that graft must have failed. So, signs of uremia. The earliest sign which you might pick up in clinic is hiccups. After that, the patient may get itchy. Not quite as itchy as they might get with jaundice, but itchiness is a sign. Loss of appetite. Then it becomes a little bit non-specific malaise. This is a really important one, pericarditis. Uremic pericarditis is really common and really under-recognized by junior doctors and medical students who haven't been on a renal ward. Uremic pericarditis is so important that the sign of having a pericardial rub, which is pathognomonic for pericarditis, is actually an indication to have dialysis. It's essential, absolutely essential, that if the patient has pericarditis with a pericardial rub, then that is a sign of uremia that would merit dialysis, being started on dialysis. By the way, guys, I know there's I'm streaming on like 4 different platforms, so if you have questions, please just put them in the chat, and I will respond at the end, if that's okay. I'm not going to be able to do it as we go through, if that's all right, just because if I pause one, I think everyone's off by 2 or 3 seconds, and I don't want to interrupt one group just to answer one question, and then every group kind of gets out of sync, if that's all right. So I will answer questions at the end, and I'll stay as long as you need me to, or as long as you can tolerate at the end of this. So, signs of immunosuppression. Remember, Cushing's signs I'm not going to go through. You're finally a medical student, so you should know the signs of Cushing's. But just remember the violation striae. I think it's a really, really useful sign at the end of the bed. The little stretch marks, which are purple colored on the abdomen, it's a really good sign. And at the end of the bed, it might be the most obvious sign at the end of the bed. Easy bruising is kind of a weak one because patients with kidney failure, they're going to get needled a lot anyway for their fistulas or what have you, blood tests. So they'll have bruising anyway. And it's hard to tell whether it's easy bruising or not. But, there are lots of signs. I think the violation striae is a great one at the end of the bed. Cyclosporin therapy. And as I say this, I'm mindful that some of you listening to me are based in London and some are outside London on the different kind of streaming things. If your renal transplant center, say you're at Hammersmith, yeah, now I'm going to have to remember this because back in the early 2000s, mid 2000s, when I was there as a medical student, it was cyclosporin. They had just started to use cyclosporin was in vogue, but certain centers use tacrolimus, and it's a little bit dependent on which center you're in. Cyclosporin classically gives you the gum hypertrophy and a fine tremor in the fingertips to look for. So you can see that if you extend their fingers out. Tacrolimus annoyingly also gives you the tremor, but the tacrolimus's bigger problem is the fact that it can worsen your diabetes or give you type 2 diabetes itself. Azathioprine doesn't give you great signs at the bedside. There's no clear sign that this is azathioprine use. Anemia you can get, and liver fibrosis. This is more just for discussion or for your SBAs. If I asked for one other problem, one other complication of immunosuppression, then you would probably tell me something smart like, well, infection, risk of chronic infection, risk of risk of reactivation of things like herpes zoster, risk of CMV, risk of all these infections. And one other thing that can be a complication of immunosuppression, it's going to be a lifelong increased risk of cancer, specifically skin cancer. It can be cancer of any organ. It can be abdominal cancer. It can be cancer of any organ. But immunosuppression increases your risk of skin cancer. And that's why some certain patients with immunosuppression end up with surveillance clinics to look for moles and things under the dermatology team. You want to keep an eye on that because they do have an increased risk. If you immunosuppress them, you knock out their natural killer cells, which are normally looking out for cancer cells, and you give them a lifelong increased risk of cancer. How would you give me, or would you be able to give me a differential diagnosis for right iliac fossa masses? Well, it could be a cecal malignancy, in which case I'd expect the patient to be cachectic. It could be a sign of Crohn's, specifically because of an inflamed terminal ileum, which is really, really common. 30% of Crohn's patients will have an inflammation in the terminal ileum, and if it becomes chronic, they can have a mass just in that region. With Crohn's patients, you'd expect to have some clubbing. You'd expect to see erythema nodosum or pyoderma gangrenosum. Sorry, I couldn't be bothered to write those out, but those are your rashes with Crohn's. I'm just throwing them in mainly just to jog your memory. You'd expect, you could get a mass in the right iliac fossa because of really massive lymphadenopathy. So big lymph node could do that as well. Of course, any kind of malignancy of any organ or anything under there, a malignancy even in theory of the muscle under there could give you a mass. So you could throw in whatever you wanted there, but these are probably commoner than that. Transplanted kidney, of course, is the go-to in this station. So what are the indications for renal replacement therapy? If you're uremic with complications of that, then you should have renal replacement therapy. The ultimate complication of uremia is encephalopathy, so drop in your GCS, comatose. So uremic encephalopathy, of course, you should be considering renal replacement therapy. Uremic pericarditis as well. Specifically, what would you look for? I'd listen for a pericardial rub, which is pathognomonic for pericarditis. Refractory hyperkalemia, so it's not great. It's not good enough for the patient to just have a potassium of 5.7. It needs to be a potassium which is properly elevated above 5.7 or 6 or whatever, and it's refractory to medical therapy. That's the key thing. So you treat it, and it fails to come down or stay down. And that refractory hyperkalemia, refractory to medical therapy, is an indication for renal replacement therapy. Refractory pulmonary edema. So yeah, of course, the patient, if they're in fluid overload, can have pulmonary edema. They can be requiring oxygen to maintain their saturations, which is the definition really at the bedside. You can pick that up on chest x-ray, but more likely clinical examination. But the furosemide shot of 40 milligrams might sort it out, or 80 milligrams. If it doesn't sort it out, that's an indication that they probably need renal replacement therapy. So refractory pulmonary edema. In patients like this, the other problem might become that their blood pressure may be teetering on the edge, and say it's 100 systolic, and they're not going to tolerate a great amount of diuretic intravenously. So you don't want to crash their blood pressure. So in that situation, again, you'll want to think about whether renal replacement therapy is a better shout. Refractory metabolic acidosis is another indication for renal replacement therapy. I would expect finally medical students to know this list inside out. Absolutely, you should. This is such a classic finals question. I would expect you to understand, and an FY1 should understand, the indications for a renal replacement therapy to be considered. And the final one is drugs. So drug overdoses, certain drug overdoses in quite a lot of cases, after you've done the first 2 or 3 ways of getting rid of the drug, ultimately, if you can't get it out of the blood, one way for certain drugs is renal replacement therapy. I got to say, in the UK, quite rarely done. We tend to be more, we tend to see much more dialysis and filtration done for chronic renal failure. Well, that's all well and good. Ritesh has just told you, I'm just playing out what your conversation is like in your head. Ritesh has just explained to me that renal replacement therapy should be done for those causes. Now, the next feared question is, give me some options of renal replacement therapy. Well, in the emergency situation, in intensive care, we don't do dialysis. We do something called filtration. Specifically, we do continuous venous hemofiltration, CVVHF. If you've been on an ITU ward round, you'll hear CVVHF written down quite a lot. And that's just fancy talk for filtration or ultrafiltration. And this is a type of dialysis. Specifically, filtration is a much gentler kind of dialysis. Let's just say it's very inefficient compared to formal dialysis. Proper dialysis from that catheter that you saw earlier, or from the fistula, is much more hemodynamically aggressive. Ultrafiltration is gentler. You do it over 12 hours or even 24 hours. You can do it continuously if you want. It won't affect your blood pressure so much, which is why it's a good idea in the intensive care units where you don't want to mess with the hemodynamics too much. So CVVHF is gentler than proper dialysis, proper in inverted commas, and it needs to be done over a longer period because it's way less efficient, but it doesn't affect the blood pressure as much. Proper hemodialysis is done 3 times a week for 4 hours each time, and you can do it through a fistula or one of these tunneled lines. There is a risk of hemodialysis causing endocarditis. Long tunneled line, you keep sticking a needle there or connecting it up and having blood move in and out. If you get bacteria in there, that line tip is very close to the heart, and it could just end up causing endocarditis, of course. And if I asked you which valve would you expect, the answer is obviously the tricuspid valve. That's the closest one. If you're getting in blood or contact from the outside world, the very first valve that will encounter from the SVC will be the tricuspid valve. So that's the most likely one. So tricuspid endocarditis. Peritoneal dialysis can be the continuous ambulatory or automated. There are different kinds, depends where you are, and depends on the patient's choice. And the complications of that are sclerosing peritonitis, which is by far and away the worst complication and something very, very much feared and has a very poor outcome. And the other one is hyperglycemia. So in your diabetic patients with poor control, it might not be a great option, mainly because that fluid that we use is full of glucose and it can increase their sugars and worsen their sugar control. And finally, you can just transplant the patient, and that's an option. That's a renal replacement therapy option, of course. What blood test would you like to do with your patient with CKD? Give me 1 second. Let me just see where we are with Q&As. Okay, I'm building up slowly. Perfect. Okay, I will come back to those questions. I'm just eyeballing them, so I'm reminding myself. All right, bloods for patients with CKD. If the patient has chronic kidney disease, properly chronic, yeah, like it's assumed this is a CKD patient, then these bloods are useful. A bicarbonate level is useful to see if they've got metabolic acidosis, because again, remember, we're thinking of all of the things that would merit moving on to dialysis, renal replacement. They're going from just chronic kidney disease to chronic kidney disease, who now needs to have some kind of renal replacement therapy. So bicarbonate, you want to check their acid base, potassium, urea. Creatinine is good to document. Not that creatinine gives you any signs or symptoms, but creatinine is an excellent marker for acute kidney damage. So you want to see what their baseline creatinine is like and keep an eye on that. Urea is kind of more chronic and is more relevant for signs and symptoms because a high urea is dangerous. You want to check the hemoglobin because they can have a renal anemia because of lack of erythropoietin. You'll want to check their calcium studies at least once a week if you're doing a ward round. You want to check their PTH. You want to check their calcium and phosphate, and that's because renal dependent 1-alpha hydroxylation is necessary to maintain your calcium homeostasis. So if you don't have that, if you've got chronic kidney disease and you can't 1-alpha hydroxylate all that vitamin D, then you will have an imbalance in your calcium and phosphate, which will result in secondary hyperparathyroidism to try and compensate for that. And if you have secondary hyperparathyroidism long enough, it will become tertiary hyperparathyroidism. Secondary is just compensating for the fact that you don't have enough calcium and your calcium balance isn't working, so your PTH in secondary just increases to maintain homeostasis. After a while, the homeostatic negative feedback fails and it becomes tertiary hyperparathyroidism, at which stage you will probably need to get parathyroidectomies. And of course, never forget, although this is technically not a blood test, but you can do your urinalysis as well. You can do a urine dipstick for protein in urine, but if you've ever been to a renal ward round in front of a renal physician, you will know that the test that they love is the protein creatinine ratio. So you can send off the urine PCR, the urine protein to creatinine ratio, which is a much better test than just a simple dipstick. Important associations. This is just to get your stuff stuck in your mind. Adult polycystic kidney disease, other things you might be worried about. Baryaneurysms in the circle of Willis, increased risk of intracerebral hemorrhage. So they can have baryaneurysms in the circle of Willis in the head, and there's a lifetime increased risk of subarachnoid or intracranial hemorrhage. And these patients, if it's an SBA, you might find that there's oh yeah, my dad had a stroke because of a brain bleed when he was in his 40s or something, and there's a big family history of that kind of thing. These patients with adult polycystic kidney disease will also have hypertension because the cysts in the kidneys will produce and release EPO, so they can get hypertensive. And for family screening, you'll want to do a renal ultrasound. That's it. So it's no radiation involved. Nephrotic syndrome. With nephrotic syndrome, the main association is hypercholesterolemia. So these patients get hypercholesterolemic. And the reason for that is they are peeing out all of their albumin, and the albumin is what all of their albumin and lipoproteins, all these proteins that they are peeing out, are what the cholesterol are absolutely essential for your cholesterol transport in the body. So if you lose all of that, you have increased free cholesterol in the blood, and you get hypercholesterolemic because of it. It's not that your cholesterol is any higher than yours or mine. It's just that you have more free cholesterol in the blood because of it, because your cholesterol transport mechanisms have broken down because you've lost all the protein necessary for it. And because you've lost all of that protein, you'll also get peripheral edema. Okay, that's kidneys done in a quick nutshell. Next, we're going to talk about this guy. If I asked you, and again you're in front of me, I would ask you, what is this on the left? And you would tell me this is palmar erythema, hopefully. And if I asked you, what's this on the right? Well, you'd tell me this is a guy giving me the middle finger. No, this is a guy who's got this is a guy with a Dupuytren's contracture. This in these patients, you want to look for. Ooh, sorry, someone's microphone isn't muted. Hassan, I can hear you. Mute your microphone. Well done. All right, cool. You'll want to look for jaundice, ascites, peripheral edema, bruising. You'll want to see at the end of the bed if you've got a stoma. I'm hoping you'll just point that out to me. Scars in the abdomen, if they're malnourished or not. Specific to the liver, you'll want to think about Dupuytren's contracture. You'll want to look for, or at least mention at the end, parotid swelling. Because what am I looking for with parotid swelling is alcohol. If they've got alcoholic liver disease, parotid swelling is associated with that. And remember that you need to technically, and you may not get this time in the exam because of course it'll be truncated, but if you are being very strict, you technically should look for 30 seconds to look for a liver flap. There are ways to achieve this in the exam if you're very slick, and I've seen people do this quite successfully. Now, of course, when I've examined people for abdominal finals, I don't fail them because at 22 seconds they put their hands down. It's fine, as long as you've looked for the liver flap. But if you want to be really slick, there are ways to do this. You can inspect from the end of the bed, and position the patient, expose all that stuff, get their consent, and go to the end of the bed, have a quick look around, look at the patients, and at that moment immediately say, so could you lift your arms up and just put them like this and show the patient what to do, and then you're already doing that while you're walking around the bedside. Gives you a few more seconds to see if they've got a liver flap. Cachexia, really, really important to mention this stuff. Loss of muscle mass, yeah, it's a sign of something chronic going on in the body, and it's something that's it's incredibly important, and it'll be very obvious at the bedside. Cachexia. The thing to look for with cachexia, beyond the fact that their arms, legs, etc., they'll have less subcutaneous fat and loss of muscle mass. If you're being very, very good, you will see that there may even be loss of muscle mass in the chest muscles in particular, which is rare to lose, but you'll get it with cachexia, or more cachexia, and protein malnutrition. Okay, so this is how I would present something like this. Mr. J has evidence of clubbing, conjunctival pallor, and palmar erythema. The jugular vein is elevated. There are multiple spider nevi in the distribution of the SVC. The abdomen is distended with dilated veins filling away from the umbilicus, suggestive of caput medusae. Come on, next. Next. There we go. I noted 8 finger breadths of smooth, non-tender hepatomegaly extending below the right costal margin. There is no associated splenomegaly. Incredibly important that you percuss out the liver, and incredibly, incredibly important that you percuss out the top end of the liver as well. You want to see that it's true hepatomegaly. You can, of course, get a liver edge because you're hyperinflated in the chest. If you've got hyperinflation because of chronic obstructive airways disease, your liver could be pushed down, right? So that's not a hepatomegaly. If you want to see true hepatomegaly or demonstrated, you need to percuss the liver to the top end as well to see where the top border is, to demonstrate that it's an actually enlarged liver as opposed to just the test being hyperinflated. He has a distended abdomen, shifting dullness in keeping with ascites, which is non-tense. Non-tense simply means it doesn't hurt. There is peripheral edema, likely from hypoalbuminemia. These findings would be most consistent with the diagnosis of cirrhotic liver disease with some evidence of decompensation. I'm going to come back to that because, of course, the thing you will be wondering is what are the signs and how would I tell if someone's decompensated? Because you'll hear a lot of people talk about decompensated liver disease, but what do we mean by that? I'll come back to it. Okay, now there's the abdominal station has the biggest variation in how to end the exam. Just 2 or 3 of these, yeah? Any way you want, but 2 or 3 of these, and there's a bunch in here. I'd like to examine the external genitalia, looking for loss of secondary sexual characteristics. I always think, by the way, guys, whatever station you get, whatever case you get, you should finish your exam trying to relate what you're going to do to that patient. So there's no point in the liver patient, in the kidney patient, to say I'd like to finish my exam by looking in the genitalia for secondary sexual characteristics. It's completely irrelevant to a renal patient, but it is very relevant to a chronic liver disease patient. I'd like to perform a digital rectal exam to look for melena as a cause of decompensation. I'd like to request a urine dipstick. Essential in everyone, I think, a urine dip. To look for nitrites and leukocytes, which may indicate infection as a cause of decompensation. You can say I'd like to examine the cardiovascular system, look for valve disease. And then if I asked you what kind of valve disease would cause liver issues, you would say tricuspid valve disease, almost certainly. So tricuspid regurgitation can cause it. Anything that irritates the right side of the heart, because the IVC drains from the hepatic vein, and the hepatic vein, if it's congested because you've got problems in the right heart, then you can have a pulsatile liver and eventually cirrhosis because of it. And urine dipstick, you could also mention glycosuria. Diabetes is a risk factor for NASH. To be honest, I could have put those 2 things together. I've just realized. Perform a neurological exam. Look for signs of chronic alcohol use, cerebellar ataxia, peripheral neuropathy. We're kind of digging into the extras here. You don't need to go that far, really. I think the top 3, which I've highlighted in pink, are quite useful. And I would probably chuck in the glycosuria with the urine dip. Non-alcoholic steatohepatitis, or NASH, is going to be probably one of the biggest causes of liver dysfunction going forward. And it's something that's going to become a big problem for our generation. I'm going to throw myself in there, not my generation. You guys are younger than me, so your generation, because it'll be a bigger problem for you than it is for us, because it's becoming more and more recognized around the world as a major cause of liver issues. Investigations. A liver ultrasound's pretty useful to actually confirm the liver's enlarged and cirrhotic. Blood screen to look for causes and signs of liver dysfunction, and we can get into those. A cause for decompensation should be sought. And I would actually throw that into the liver presentation. I would look for causes of, if the patient's decompensated, I would say I would look for causes of decompensation, hoping for the question, what are the causes of decompensation, which we're going to talk about. Whenever you're talking about a big liver, if we step back from the chronic liver disease patient and just say hepatomegaly and nothing else, yeah? Just remember to present these things. It's essential. The size, okay, I would hope everyone knows this. Examine for the top edge as well and give me size of the liver. Most gastroenterologists would prefer if you use finger breadths, yeah, as opposed to centimeters. So how many breadths or how many fingers underneath the right costal margin is it? Is it smooth or irregular? Yeah, the texture is important. Just whatever you feel about the texture, yeah, it feels smooth. I felt it was irregular. Is it tender or not? And of course, you'll ask the patient before you touch them, does it hurt anywhere? And if the patient says it hurts there, you obviously you don't want to go to pressing there and causing pain, but presumably it'll be a non-tender hepatomegaly in the exam. What are the causes of hepatomegaly? Well, cirrhosis or chronic liver scarring is the commonest cause. You'll never find this in the exam. It's very hard to hear. Hepatic venous hum. I've never heard it. I'll just straight up tell you that. Yeah, and I'm a cardiologist, so I use my stethoscope. Well, I used to use it before echo a lot, and I don't know what that sounds like. I've heard it on YouTube and stuff, and I'm pretty sure I've never heard it in real life. But hepatic venous hum is pathognomonic for cirrhosis. It might pop up in SBAs, which is the only reason I'm giving it to you here. So if you see hepatic venous hum in an SBA, you can stop reading. The answer is cirrhosis. That's pathognomonic for cirrhotic liver disease. But it is, I have to say, in real life, I'm not sure what that sounds like. So I'm imagining you probably don't need to know. So other causes of a big liver malignancy. It may be primary or secondary. Primary hepatocellular cancer or secondary metastatic deposit. It could be congestion of the liver because of heart failure. And I use heart failure in inverted commas. Technically, it'll have to be right heart congestion to get that. But of course, congestive cardiac failure includes both right and left, so that's fine. Constrictive pericarditis can do it. Pulsatile liver could be from tricuspid regurg. So some kind of right heart issue. All of these things cause right heart issues and could cause congestion, and liver congestion can lead to cirrhosis. Just checking, making sure the battery is good. Sorry, don't want the laptop to crash. All right. Other causes of hepatomegaly, and to be honest, guys, if you've used any of the, the book Cases for Paces is pretty good. It's thin; it'll be in your library for sure. You can nick that or get it out. I'm sure your mates will have it. It'll give you the 3 C's and the 3 I's. There are lots of mnemonics. I'm not a big fan of them personally, but cirrhosis, cancer, i.e. malignancy, congestion, those are your 3 C's. And then the 3 I's go something like this. And I don't know what the third one is, actually. There's 2 I's in here. Infiltrative disease, sarcoid, hemochromatosis, amyloid. So any infiltration from outside the liver can do this. You can have iron deposition. You can have sarcoid. You can get amyloid protein deposition, inflammation of the liver, hepatitis, obviously, which can be because of alcohol or viruses or autoimmune. And structural variance is kind of small print stuff. So a Riedel's lobe can feel big, and it's not actually an abnormality. It's just a normal variant. In the story, in the history, you'll want to take a note of these things. So your patient and this will be more about actually being a history station in a patient with a big liver. Hemochromatosis patients will have a long history of diabetes. They may have a TAN. You'll want to check the ferritin. If it's a primary biliary cirrhosis patient, I think I'm actually going to discuss this in a bit more detail later. I think I've still got the slide in there. PBC, those patients tend to be women, 40 plus, and 90% of the patients with primary biliary cirrhosis or cholangitis are women. And the key feature in the history, the absolute most important feature, is the fact that there is itching. Itching is the most prominent symptom. They'll also have xanthal asthma on examination, and they may also have jaundice. Okay, let's talk impaired synthetic function. So to look for what the liver does is it clears the blood of a bunch of toxins. It also produces stuff, and that's the synthetic function. And specifically, the vitamin K dependent factors for your coagulation pathway are produced in the liver. So if your liver isn't working, one sign is that you're coagulopathic. The coagulopathy can be measured, of course, and you can measure it by doing the INR test, so the prothrombin. If you look for the international normalized ratio or prothrombin, you'll find it's elevated, and that is the sign of impaired synthetic function. That's very readily examinable. The other thing the liver produces is albumin. So the liver is producing all of your albumin. And if your albumin's low, you can have peripheral edema. You could also get ascites because of it. And this is something that's interesting. At least it's interesting to me. Once you understand this, a lot of the liver signs becomes quite obvious why they would get this. Now, I don't like to teach signs unless you can explain them. Because I told you at the beginning, these patients have lack of body hair. They might have, I haven't mentioned gynecomastia, but they can do if they're men. They can have testicular atrophy, loss of secondary sexual characteristics, palmar erythema. Why are they getting that? All of these signs are because of an increase in the patient's relative estrogen to testosterone ratio. Yeah. So the reason they're getting that is because quite a lot of your estrogen is bound up to albumin and sex hormone binding globulin in the blood. And if your liver isn't working and is not producing protein, albumin, sex hormone binding globulin as much, then your free estrogen will increase in the blood. Again, it's similar in concept to the fact that when you're in nephrotic syndrome, you're peeing out all of your protein and your free cholesterol goes up. Your free estrogen is going up not because you're producing more of it, but because you can't bind it up in the blood. And if you've got a higher estrogen to testosterone ratio because of that, then you will end up with signs of having increased estrogen. Those signs include spider nevi and loss of your secondary sexual characteristics for men, lack of body hair, gynecomastia, testicular atrophy, palmar erythema. And it is the case that if you have higher estrogen levels, then you tend to have a bit more vasodilatation. Investigations in chronic liver disease. Well, I think a digital rectal exam is pretty important, so I would mention that every time. I think it's essential. You'll want to think about an infection. If a patient has decompensated or they've become acutely unwell with chronic liver disease, you have to think about infection. particularly if they've got ascites, you want to think about whether they've got spontaneous bacterial peritonitis. And the way you investigate for that, beyond actually examining them and seeing if they've got abdominal tenderness, is doing an ascitic tap and sending the fluid off for an urgent white cell count and gram stain. If the neutrophils are above 250, we would treat that with antibiotics. So if they've got a neutrophilia in their ascitic fluid. Blood tests that are useful, well, alpha fetoprotein is useful because it can tell you if they're getting hepatocellular carcinoma. A liver ultrasound, of course. Bloods, I think this is, I think most of this should be obvious. I really believe that you would come up with most of this stuff, right? Hemoglobin, renal, liver screen, obviously. You want to check their alk-phos, etc. The MCV, if their MCV is low, it could be because of variceal bleeding. If the MCV is high, it could be because they've got alcoholic liver disease, because alcohol can cause a macrocytosis. Neutrophils, infection, hemoglobin, obviously, because of variceal hemorrhage, etc., or chronic anemia of chronic disease. Renal function, liver function. The reason I throw in the renal function in there is because it's a good general marker, but the other specific thing long-term is you're looking for hepatorenal syndrome. Coagulation screen, specifically the INR, is important. Also, if your patient's got variceal hemorrhage or risk of it, you'll want to know that their coagulation screen is okay. Albumin for obvious reasons. You'll want to do a viral liver screen, so hepatitis B, hepatitis A, hepatitis C. These are the tests that would be a good screen. So hepatitis B surface antigen, hepatitis A IgM, hepatitis C antibody. An autoimmune screen, so immunoglobulins, anti-smooth muscle antibodies, ANAs. To be honest, the autoimmune screens evolved with time. So when I wrote this slide a few years ago, it may be that it's your local guideline might be a bit different. When you get to the hospital, don't be surprised that every hospital has predetermined blood tests that constitute a heart screen or a liver screen or whatever. So they may be different where you work, but generally speaking, this is useful. Certainly for autoimmune hepatitis, these are specific. Oh, sorry, excuse me. Clues to chronic liver disease. If they've got signs of tattoos or intravenous drug use, then viral hepatitis would be something we'd consider. I got to say, this is beginning to get a little bit old school, because it used to be the case that, the kind of classic scandal of the 80s was that unused or unclean needles, before people were more aware of Hep B and Hep C, the Hep C in particular was transmitted via these routes. But it's more common now, certainly tattoo parlors, but IVDU, of course, remains an issue, but it's not going to be that common anymore. Xanthal asthma is a sign of primary biliary cirrhosis. It's a good sign. Having a tan is a sign of hemochromatosis, or that you've been on holiday, of course. So don't just assume every guy with a tan has hemochromatosis. Could just be that he's been out. Parotid swelling, neuropathy, gout, cerebellar syndrome, all these signs could be signs of alcohol use. Parotid swelling is an interesting one. You just have to feel on either side of the cheek for parotid swelling. It shouldn't be painful, but the signs that they've got parotid swelling can be quite obvious at the bedside. You can look for things on the blood, of course, and the gamma GT is a nice one, and an elevated MCV, so macrocytosis, peripheral neuropathy, gout, commoner in patients with alcohol abuse, and cerebellar syndrome ultimately. You can look for signs that this patient has increased risk of non-alcoholic steatohepatitis because they've got the metabolic syndrome, they're diabetic, hypertensive, etc. African Caribbean patients, sarcoidosis. This is getting into more SBA territory. Unlikely this will come up in the exam. And Wilson's disease, in theory, gives you liver involvement plus a dysarthria or a tremor. And you can, and I'll get lots more into Wilson's when we do neuro, so we're not going to do it in great depth here. Female patients with vitiligo, you're wondering about autoimmune disease. Big barrel-chested patients, you're wondering about alpha-1 antitrypsin deficiency. So your patient who's got chronic obstructive airways disease plus liver, there's only a few things that'll ever combine that. And the big one is going to be alpha-1 antitrypsin deficiency. So if they've got signs of COPD at the bedside, plus they've got signs of liver failure, alpha-1 antitrypsin deficiency is the thing I'd be thinking. Signs of severity, well, cachexia, organ failure, if they've got bruising, if they've got signs of, so all of these are signs of lack of synthetic function. So bruising, coagulopathy, peripheral edema because of lack of albumin. Ultimately, if they're developing shunting, portal systemic shunting, because they've got portal hypertension, then they can develop varices and fetal hepaticus. Again, you're not going to be smelling their breath, certainly not in the COVID era, so it's unlikely you'll pick that up. But this is more, I guess, just for discussion. Of course, now we would never ever do that. We'd all be wearing masks. Amazing. I kind of just as I said that, I just realized how many different things we're probably never going to be able to do and examine like they had in the old books because of COVID. And you will lose out on the value of smelling your patient's breath. You poor souls. Portal hypertension. Portal hypertension is a sign of portal hypertension develops because of increased pressure in the portal vein. And the reason you get that is because of scarring in the liver. So a scarred liver will resist blood flow through it. Simply, that's all it is. And if you get this pressure building up in the portal vein, you will end up with a backflow or backlog of blood that can't get through. And it'll result in splenomegaly, ascites, caput medusae, and ultimately varices. I did a little video on my YouTube explaining portal hypertension in detail because I thought it was one of these things that requires like a good 6-minute dive to understand the physiology behind it. And I think it's not terrible. So if you aren't completely bored, you can go and listen to that at some point. It'll be on my YouTube. Causes of decompensation of liver disease. By the way, guys, I'm aware it's 7:28. We've just got a couple more slides in the wait time. Causes of decompensation. So, I mean, decompensation is defined by ascites, jaundice, encephalopathy. Any one or two of these will be a sign of decompensation. Certainly, encephalopathy is a big one. Alcohol. So, if a patient drinks, they will decompensate. Sedatives. So, your confused patient with chronic liver disease, you want to avoid giving them benzos. It'll make it worse. NSAIDs, because they can worsen renal failure. If you diurese them too much, say because of their ascites, and they become hypokalemic in particular, if you drop their potassium, they will have reduced renal ammonia clearance and they will decompensate. If you give them too much protein, or they have too much protein in the gut because of a GI bleed, because that blood is a nice source of protein, or they go into renal failure, then they'll have a good reason to decompensate as well. Constipation. One of the things you'll be aware of if you've been on a liver ward round is how they really meticulously monitor these patients for how many bowel movements they're getting. You don't want your liver patient with chronic liver disease to be constipated. You want them to have frequent bowel movements to make sure that they don't retain protein and they have an increased protein load, which will cause decompensation. Infections can cause decompensation as well, of course. And finally, and everyone always forgets this one, hepatocellular carcinoma. If you develop liver cancer, you can decompensate. I'm sorry it's a busy slide, guys, but causes of liver decompensation is one of these things that, again, there's not that much that can come up in the medical abdomen exam. That's why the chronic liver, you can get fairly deep on. There are quite a lot of things they can ask you about, and causes of decompensation is one of them. I would advise you to just remember 2 or 3 of these, and now that you've heard the rest, you can talk around it if it comes up. So just remember a couple of these: alcohol, constipation, infection. Those 3 are good. So, a hepatologist will really respect that you remember the alcohol, that you remember what were the other 2? That infection, spontaneous bacterial peritonitis, can cause constipation, and that's caused by E. coli. And constipation can cause decompensation. These 3 things, alcohol, infection, constipation, I would suggest would be the important ones to remember. Any of them are good, of course, but I think those 3 things in particular, if a junior doctor remembers that you're doing pretty well. Signs of hepatic encephalopathy. If the patient is sleepy during the day and awake during the night, that's actually the first sign, diurnal sleeping pattern disturbance. So you can actually get that on just taking a history and see if they've got the first signs or first stages of hepatic encephalopathy. Having the liver flap comes after, then bradykinesia, and then you get on to the stuff that leads on to coma, areflexia, decerebrate, and then coma. And of course, by here, your GCS is dropping and your patient's pretty unwell. So I'm hoping you will have picked it up before. So it goes kind of in, their mood will deteriorate like this. They'll start with sleepy, then they'll be drowsy, agitated, comatose. Okay, one last slide, and I'm going to stop. Neurological complications of alcohol excess. I actually alluded to a lot of this already, but Wernicke's encephalopathy I haven't really talked about. Remember that. That's incredibly, incredibly important. Wernicke's encephalopathy. It comes up, at least, at the very least, you should be aware. Never forget that. We always learn it in first year clinical and we kind of forget it after that. Cerebellar syndrome can also happen because of chronic alcohol use. Very important to remember that one. Ataxia, tremor. Delirium tremens is actually a complication of neurological excess, because if you start withdrawing, you'll start getting DTs, and therefore is essential to remember. Guys, I think that is the last slide, actually. That's it. We finished there. Why don't we, I'm going to leave this slide up, and why don't we go to questions? Let me have a look at the questions, and don't worry, I won't put out your name as you ask questions, so I won't put you on the spot. But if you want to put the questions in the various chats, I'll answer them anonymously, so no one knows you're asking this. Is the dialysis catheter also called a TAVI? No. Sorry, Tessio, isn't it? So I think you've misspelled that. Tessio catheter. Yes, it can be. Tessio is a brand name, so I mean, a tunnel dialysis catheter, it depends where you are, but yeah, in West London and probably most of East London, it is called Tessio catheter, but a tunnel dialysis catheter, it's just got 2 ports. That's the important bit. You can use the trade name if you want, doesn't matter, but it's a dialysis catheter, it's tunneled, and that's the important bit. Could you go over how to tell if an AV fistula has been used recently? Yeah, if an AV fistula has been used recently, you'll probably see signs of bruising. So if I go back, I'm going to pull up that slide, and you'll see why I thought that guy was being used recently. I'm just going to hold this down. It's the easiest way. Is there an easier way? Nope, it still goes one by one. Great. Let's see. Other questions while I'm doing this. 1 second. Isn't hypercholesterolemia nephrotic syndrome connected with 2 theories? Liver produces more lipoproteins and other proteins cause of low oncotic pressure. Lipoprotein lipase is lost in the urine. Well, you're quite right. You do lose the lipoprotein lipase in the urine, and that is one of the reasons, certainly. But actually, the hypercholesterolemia nephrotic syndrome, I believe, has not been proven to be because of the increased production of lipoproteins. I think it is actually a combination of the fact that there isn't as much there is more free cholesterol. Is GGT for prehepatic jaundice or alcoholic liver? So gamma GT will be elevated if you have a, I hate the terms prehepatic jaundice, I gotta say. If gamma GT will be elevated along with alkaline phosphatase if you have a cholestatic picture. So if you have cholestasis, you'll get an elevation. Gamma GT can also be elevated specifically by alcohol exposure. Oops, sorry, backwards. Where's that damn picture? Goodness me, how far back did we go? There we go. So there's the bruising on the, and this one actually you can see a needle mark here. So I think just the fact that there's bruising around there is a sign that it's been used. Is testosterone not bound to SHBG and albumin? Also, why is there only a relative increase in estrogen? So yes, it is. It absolutely is. But it's the more important role is the estrogen to testosterone ratio. Estrogen is more highly bound, and therefore the ratio is imbalanced in chronic liver disease, and that's the reason these patients have a relatively more estrogenic picture at the end of the bed. I don't even know if that's a word. Is GGT for prehepatic? Oh, I've answered that one. You can ask private questions on the Zoom as well, so no one else can see. That's pretty clever. Cool. Or as you guys would say, coolio. Is that it? Any other questions, guys? Otherwise, we finish up. Leave me some feedback, and I'd appreciate it. I'm gonna do another one next week, and I might do a stoma, a medical stoma case, because I'd like to talk about inflammatory bowel, and we didn't get to do that today. So I think it'd be nice to kind of do an overlap. It doesn't have to just be gastro. We can do different things. Is there a different? This is a really good question from Mr. X. Is there a difference between albumin creatinine and protein creatinine? Well, yeah. I mean, the albumin-creatinine ratio is more specifically used to look for diabetic nephropathy, and the protein-creatinine ratio is more used specifically to look for nephrotic syndrome. So they are different. They are looking. The albumin-creatinine ratio is more specific for specifically diabetic nephropathy, whereas the PCR is more standardly used for for nephrotic syndrome. Actually, you can use them either way, but obviously the ACR is just looking at albumin, whereas protein is looking for generic protein loss. And the ACR is a much better marker for diabetic nephropathy. Is raised AST associated with alcoholic liver? Yes, it is. Is gamma GT more likely for alcoholic liver? Both AST and gamma GT are. AST is increased in any kind of muscle damage, heart attacks, and lots of other things. So AST is technically less specific for the liver than the rest of it, but gamma GT certainly is, and AST is. The classic story, which in my finals course I delve into the liver blood test in way more detail, is the AST to ALT ratio, and that can give you a picture of whether it's alcohol or non-alcoholic liver, but it's a little bit too much in depth to go into in just a 1 hour talk. Any other questions? Quoth Loliet. I suspect that's someone who reads The Name of the Wind. Great book. Great book. Recommended if you're bored of cheese and onion. Someone named Aragon says Tis. Cool. I think that's probably philosophical. Tis, like it's like Shakespearean or something. If you have any more questions, guys, you can just message me on Facebook or whatever. But do share this with final years if they're unaware of it, or tell them to stay clear if you are aware of it and you think it should be avoided. But of course, if you share it, I would be grateful. See you guys. Message me any questions you have. I'm gonna head off. Oh, thank you. Some 1 or 2 nice comments coming through. Cheers, guys. It's been a pleasure. There's one more question. Next time, could you talk about liver function tests and what they indicate? Yeah. See, the thing is, when I do my proper course, there's quite literally half a day on the liver. There's like nearly 2/3 of a day on cardiac. So it's hard to narrow it down into just an hour. Of course, I'd love to just talk and talk and talk, if you guys can tolerate that. But it's always difficult to put it all in, and I have to kind of pick and choose what's the most high yield thing for the most people. So that's the only reason I didn't do that. But of course, I'd love to go into blood tests with you, Matt, anytime. But it's probably not great to do it on this and take up the whole hour, because we could. See you guys. I'm going to head off now. Message me, please, privately if you have any other questions.